Good afternoon, everybody, and thank you so much for coming. And I hope you've had an opportunity to get some lunch and beverages and fill out the pre-meeting questions. Really happy you're here. Hope that you're enjoying SUO. I think it's been a phenomenal meeting, as always, and kudos to the planning committee for putting on such a great program. Certainly not lacking in amazing content and amazing speakers. We're honored to have you here, and this is a CME program. As you can see, navigating therapeutic choices in prostate cancer. We're going to make an attempt to go through several different areas of prostate cancer, from the sort of challenging high-risk localized prostate cancer, BCR, oligomets, low volume, high volume, MHSPC, and then MCRPC. And we're going to finish it all in about 5 minutes, and then you're going to have another 55 minutes free. No, I'm kidding. We're going to take the full hour. So I'm really happy to be joined by good friends and colleagues, Gordon Brown, uro-oncologist in New Jersey, a dear friend and colleague, Tanya Baraskis-Dorf. She is a phenomenal medical oncologist and a great supporter of uro-oncology and the multidisciplinary work that we all do. So I'm really happy to have them here. It's a real treat to be able to discuss challenges in these different disease states. Really appreciate the support from PeerView and Zero. Zero is really one of the premier leading advocacy organizations for prostate cancer patients and their families. We're sponsored. It's multi-sponsored, which is always great. It's CME. You can collect your data for this. There's a QR code. If you haven't logged onto it, I'll show it to you in a minute. Also, it's important you get onto that, not only for your CME, but to ask us questions. Really thank Astellas and Pfizer and Bayer and Janssen and Novartis. It's a really great multi-grant support we have here. Please complete your pre-event survey. We'll want you to do the post. That's how we learn and make these programs better. And we really want you to keep in real time, send in your questions. There will be prizes given at the end. I'll announce them before we leave who sent in the best questions. So we have folks online. Please send your questions in too. It'd be great. Fill out the surveys as well. And you have the code. Here's the code. And we will be able to give out a bunch of these Amazon gift cards. So we really appreciate, interesting, provocative, even comedic questions. We'll take all of those too. So here's the code. You can download that. Here's the web link for PeerView. You will be able to get all these slides, so you don't need to worry about taking photos. Slides will all be available to you. And they have a whole bunch of other really great patient and healthcare provider practice aids on their website. It's remarkably helpful. What are our goals today? We're nothing if not without understanding the safety and efficacy of new therapies, whether they're parenteral or oral, whether they're as monotherapy or in combination. Uber important, especially for uro-oncologists. Our medical oncology colleagues have always been nurtured in the importance of adverse event safety, and we're now really getting into that and the importance of systemic therapies. I saw my good friend Paul Lang is in the room. Paul Lang is really one of the leading pioneers in really getting uro-oncologists to recognize how important systemic therapies are under his chairmanship at UW, but also in the SUO and the AUA. And so it's really important to understand for our patients, shared decision-making, the multidisciplinary team, personalizing strategies, and we really want to always be able to provide a patient-centric discussion. So we have unmet needs. I talked about this is our agenda really for today. All these different advances, a lot of great data that we're going to just show you in a highlight fashion. But one of the kind of the challenging things is we see an underutilization, a lack of implementation of the guidelines and level 1 evidence. And so if you have thoughts on it, we want to hear about it in your questions. And it's ultimately, at the end of the day, it's optimization of care, whether it's intensification or de-intensification. I think both can be thought of as synonymous with optimization. Really appreciate the folks at Zero. They are really one of the champions for getting really good education out there to families and our patients. And they, bring in resources from, PCF and PCEC and many other really cutting-edge nonprofit organizations to help patients and their families make informed decision-making. So with that, let me hand it over to you, Gordon, and thanks.
Great. Thanks, Neal. Welcome, everybody. We're going to kick off the conversation this afternoon discussing therapeutic strategies and navigating the management of high-risk localized disease, as well as those patients with high-risk biochemical recurrence. Obviously, appropriate risk stratification is going to be the cornerstone to effective management in patients with newly diagnosed prostate cancer. It allows us to institute appropriate therapeutic paradigms to maximize cancer-related outcomes and hopefully minimize cancer treatment-related morbidity. If you look at the data, newly diagnosed prostate cancer patients in the United States, about 15% of those patients come to us with high-risk features. The NCCN defines a patient with high-risk prostate cancer as one who has one of the following characteristics: a clinical T3A tumor, that patient who has grade group 4 or higher disease on biopsy, or that patient who has a PSA that's greater than or equal to 20 at the time of their diagnosis. The NCCN also provides some guidance with respect to defining very high-risk disease, which is that clinical T3B/T4 tumor, that predominantly grade group 5 patient on biopsy, that patient who has more than one high-risk feature present at the time of diagnosis, or that patient who has 4 or more samples positive for grade group 4 or higher type disease. We recognize that these patients are at high risk not only for biochemical recurrence of their disease, but for systemic progression and ultimately death from disease. And we know that there are certain clinical pathologic features which are intimately associated both with prostate cancer specific as well as overall survival in this high-risk group of folks. Historically, we haven't been quite as effective as we'd like to be in terms of modifying the natural history of those patients who have high-risk localized disease or those patients with high-risk biochemical recurrence. And this kind of presents a unique unmet need in this patient population to do better and improve outcomes in a high-risk group of folks. And with new therapeutic options come new opportunities, right? We now have availability of second-generation novel hormonal agents, which we can use in potentially well-designed phase 3 randomized clinical trials to treatment intensify patients, both in the perioperative as well as in the radiation setting, to hopefully improve outcomes. In the subsequent slides, we're going to walk through a variety of these phase 3 randomized trials. Some of them have been fully accrued, reported out, and are now paradigm changing with respect to management of this group of folks. Some are fully accrued and are not yet reported out as they're event driven. And some are going to be kind of open and ongoing and accruing. So we'll kind of walk through these kind of one by one here. All right, so these are the 4 trials that we're going to highlight in phase 3 trials in clinically localized high-risk or very high-risk patients in either the radiation or perioperative setting. And we're going to talk about 2 trials in the high-risk biochemical recurrent patient population. Starting off with some recent data published by Gerhard Tard in Lancet in 2022, they looked at some meta-analysis from the Stampede platform, right? This is a unique trial platform, which is a multi-arm, multi-stage platform, which has been really kind of revolutionary and somewhat very unique in its design. It allows it to be almost pliable over time to some degree. And the question that he tried to ask and answer here, I think did so very effectively, was is treatment intensification with the addition of abiraterone plus prednisolone in patients scheduled to undergo radiation plus ADT therapy for their high-risk clinical localized disease, is that improve their metastasis-free and overall survival? And based on the results from the meta-analysis, we certainly see significant improvements in MFS as well as OS. Hazard ratio in the MFS patient population is 0.53, and the OS patient is 0.6, arguably making the addition of abiraterone plus pred to ADT and IMRT a new standard of care for the management of these patients with high-risk localized disease undergoing radiation therapy. This is a proof of principle phase 2 trial that was really looking at the proof of principle of treatment intensification in the adjuvant setting post-operatively for patients. It's called the APA-RP trial, a multi-center open-label single-arm phase 2 trial, 108 patients, all of whom had high-risk localized disease, conventional scan imaging negative at the time of diagnosis, underwent radical prostatectomy, had a nadir PSA of 0.2 or less, and they went on to receive adjuvant therapy. They had adjuvant therapy in this clinical scenario with ADT and apalutamide for 12 months. And then they assessed their primary endpoint of the trial was biochemical recurrence-free survival at 24 months after therapy completion. And as you can see from the, this Kaplan-Meier curve, I don't think I've ever quite seen a Kaplan-Meier curve like this. 100% biochemical-free survival at 24 months following completion of therapy. Certainly supports the notion of treatment intensification in a well-selected patient population as a hypothesis that certainly needs to be further studied and evaluated. They also looked, I think, at some important secondary endpoints in the trial, specifically the ability to regain serum testosterone levels to greater than 150 at 18 and 24 months. This really speaks to quality of life, right? So we've achieved an improvement in outcome from a BCR perspective. Now we want to make sure that their quality of life of these patients are hopefully tracking in the same direction. They also looked at relugolix as a monotherapy in standard dosing when used in combination with apalutamide and the ability to maintain castrate levels of serum testosterone, and it was successful in doing so. So I think a nice, well-designed, kind of hypothesis-generating trial, which really serves as a proof of principle for intensification in the adjuvant setting in the appropriately selected patient. So moving on into the perioperative setting with Proteus, this is a large phase 3 trial, 2,000 patients. This is looking at those folks with high risk, locally advanced, and very high risk prostate cancer, conventional scan imaging negative again, scheduled to undergo radical prostatectomy and pelvic lymph node dissection. They're going to be randomized 1-to-1 to receive neoadjuvant apalutamide plus ADT, followed by surgery, followed by 6 months of adjuvant therapy, again with apalutamide and ADT, against the placebo comparator arm, including ADT. Primary endpoint of this trial is a complete pathologic response, as well as metastasis-free survival. This trial is completely accrued, is closed, but it's an event-driven trial, so we haven't seen any reports on this yet, but I think we're anticipating some data within the next calendar year, potentially. Obviously, it depends upon the event reports. Switching now from the perioperative patient to the radiation-based patient, this is the Atlas trial, right? This is those patients, 1,500 of them, high-risk localized prostate cancer. They had, again, conventional imaging negative with either neoadjuvant and concomitant APA plus ADT, in addition to adjuvant therapy for 2 years compared to a placebo comparator arm. Primary outcome in this trial is going to be metastasis-free survival. So hopefully this will, when this trial again is fully accrued, has yet to read out. It's an event-driven trial again, looking at MFS, and hopefully we'll have similar impressive outcomes as we've seen on Stampede. The last trial we're going to talk about in the high-risk localized setting is the DASL-HiCap trial. This trial is actually open and actively accruing. This is looking at the treatment intensification with darolutamide in patients with very high-risk disease who are scheduled to undergo radiation therapy, or in those patients with PSA persistence following failed radical prostatectomy, or quick PSA recurrence following radical prostatectomy within 12 months of surgery. They're going to have Daro 600 milligrams twice a day plus ADT for 96 weeks compared to a placebo comparator arm. Again, primary outcome of this trial is going to be metastasis-free survival. Right, so we've seen some treatment intensification in the high-risk localized patient, both in the perioperative setting as well as the radiation patient population. We're going to switch gears a little bit here and talk about the high-risk biochemical recurrent patient, okay? This is the EMBARK trial. This is Dr. Shore's trial that was presented as a plenary and subsequently became a New England Journal of Medicine publication this year. And this is really a paradigm-changing trial for the management of specific patient populations with high-risk biochemical recurrence. These patients had PSAs greater than 1 at the time of trial enrollment. In the post-operative setting, they had PSAs 2 plus the nadir in the post-IMRT setting, doubling times inside 9 months, which defined them as high risk, and conventional scan negative. They were randomized into one of 3 arms. Over 1,000 of these patients on trial. They were randomized into enzalutamide plus ADT as a combination, to a placebo plus ADT, and then lastly to a enzalutamide monotherapy arm. They continued on trial for 36 weeks. If they were able to achieve a PSA less than 0.2, they were allowed to undergo treatment de-intensification, which I think actually is a really strong point of this trial, where they were de-intensified. If they did not achieve a PSA less than 0.2, they maintained on their current therapeutic paradigm. Primary endpoint of this trial was looking at metastasis-free survival between the enzalutamide combination and placebo, with the secondary endpoint looking at MFS between placebo and enzalutamide monotherapy. All right, so looking at the primary outcome of this trial, this is the MFS in the enzalutamide combination arm compared to the placebo arm. We see dramatic improvements with respect to risk of death or metastatic progression, a reduction in risk of 58%. We see similarly impressive improvements in PSA progression, where we're seeing a hazard ratio here of 0.07. Really remarkable PSA responses, and supports, again, potentially therapeutic intensification in well-selected, high-risk biochemically recurrent patients. They also looked at the enzalutamide monotherapy arm, compared that to placebo, and they, again, saw significant improvements as it relates to reduction in risk of metastasis-free survival, a key secondary endpoint of the trial itself. So we know historically how this behaves. It's clearly, it seems to be impacting the disease trajectory and natural history of those folks with high-risk BCR. And we know historically the toxicity and biological activity of enzalutamide in this patient population. So we're interested to see if there's any new signals, right? We seem to be changing potentially the natural trajectory of this disease state, but are we doing it with increased toxicity? And this has been FDA approved, at least enzalutamide, since 2012. There were no new safety signals observed in the EMBARK trial. Typical, safety signals come through for hot flashes, fatigue. It appears that some of the hormonal side effects occur a little bit more quickly in those patients on the combination arm compared to the placebo arm. And there does seem to be some sexual activity preservation in the enzalutamide monotherapy arm compared to the placebo arm. All of which suggests, one, predictable toxicity profile, one that we're familiar with and comfortable with, and two, no increased signals or concerns, while we're improving MFS in this high-risk group of folks. And additionally, we talked about treatment de-intensification when we started the conversation around the EMBARK trial. This is equally important, right? So not only do we want to intensify therapy to change the natural history of disease, which we've demonstrated, I think, very effectively with MFS endpoints, but if possible, we want to take patients off of therapy, right? And because there's a variety of endpoints, financial toxicity, physiologic toxicity, amongst others, that if we can minimize their exposure to drug and still maximize their outcome, that's kind of the needle we really want to thread here. And the data here supports that these patients were much more likely to come off of therapy or undergo de-intensification in the enzalutamide combination arm or the enzalutamide monotherapy arm compared to the placebo arm, suggesting that these patients are more successfully de-intensified if they receive enzalutamide for management of their high-risk BCR. Lastly, we're going to talk about the ARISTEP trial. This is, I think the PI here is Alicia Morgan's. This is an open and actively accruing trial, and this is looking at, again, high-risk patients with biochemical recurrence, looking at darolutamide plus ADT, treatment intensification, in a pretty select group of folks. This is a little bit of a unique trial in as much as that when they designed this trial, they're looking at conventional scan negative, PSMA scan positive, with at least one or more area of concern. They had PSA doubling times, which were a little bit more generous than was seen in EMBARK, less than 12 months, and baseline PSA criteria, which would be consistent with most of these trials for their enrollment. They are following these patients with PSMA scans over time, which is a unique approach. PSMA scans almost exclusively here are looking for PSA progression. And the treatment paradigm is intensification with darolutamide plus ADT for 2 years compared to placebo, with a primary outcome here of radiographic progression-free survival as assessed by PSMA PET. So I think we have evidence to suggest that treatment intensification and the data that we have based on STAMPEDE significantly improves outcomes in high-risk patients scheduled to undergo definitive radiation therapy plus ADT when we intensify with abi-pred. And we have some very good level 1 evidence in the high-risk biochemical recurrence setting based on the EMBARK data, And I think it's going to be exciting to see how these additional trials play out both in the perioperative setting as well as in the radiation patient population to improve outcomes in this high-risk group of folks. So,
Thanks, Gordon. That was a great overview of a lot of data. It's really exciting, right? We saw this landmark paper from Stampede, which sort of changed high-risk patients receiving 2 years of ADT, clearly benefit from adding abiraterone acetate and prednisone incorporated into the guidelines. Gordon just reviewed, you have additional ARPI augmentation to that same patient population. Now, data will be forthcoming with apalutamide, enzalutamide, and darolutamide. Super interesting. And now also, we don't have any level 1 evidence that neoadjuvant or perioperative therapy has been beneficial for our high-risk patients undergoing RP. We did that phase 2 study, and now we have the Proteus that'll hopefully have a readout sometime in the next year. So things are really moving rapidly. I guess the biggest thing is while you're taking an opportunity to answer this, please. Boom, there it is. Okay, so yeah, really nice to see. Well, the numbers are still coming in, but yeah, based upon the pre and the post, a lot of folks really are saying, yeah, they're getting that great work done by Stampede and adding abiraterone acetate and now incorporated into the guidelines. Nice to see really a very small percentage not signaling on 12-month ADT alone and going downward. So that's really great. Here's a question that got popped up. Gordon, let me ask you this, and then Tanya, you as well. If we have this embarrassment of riches, so Atlas reads out positively, Enzarad reads out positively, and Dasal HiCap reads out positively, in addition to the Stampede, let's assume we're in a world a year from now where we have the choice of the 4 different ARPIs and a patient's undergoing 2 years of ADT for high-risk localized disease and radiation therapy. How are we going to make that decision? I guess it's really kind of an extension of how do you pick your ARPI? Maybe Gordon and then Tanya.
Yeah, I think it's going to be difficult to cross-trial compare, right? So I assume they all meet their endpoints. We're going to look at. I kind of come back to toxicity, access, and efficacy, right? Being the 3 kind of landmark things that we look at. And that's going to be different for every patient. So I think it's a patient-to-patient conversation. Assume they all meet the mark with respect to improvements in MFS that they're planned to, and assuming it's going to be a out-of-pocket cost to the patient. It's going to be the patient comorbidity conversation, and it's going to be sitting down and kind of counseling those in real time.
So let me change the question a little bit now for you, Tanya, because I totally appreciate Gordon's response, but flipping it into the shared decision making. You're in your busy clinic, and you're piling up. You've got calls to do, like everybody here. You've got a packed clinic. They're adding on more patients. How are you doing that shared decision making now? A year from now, you've got 4 positive phase 3 trials. Patient says, I don't want a prostatectomy. I'm going radiation. I agree to the 2 years of ADT. And now, how do you do this efficiently?
So it's similar to what we're doing in metastatic hormone sensitive, right? Where we have a choice of agents. I definitely do not walk through every single agent with each patient. I don't think any of us really have that time. I think we can look at the medications the patient's on and their comorbidities and go in with what we think would be the optimal, and then also mention there are others and maybe high level, what are the advantages, disadvantages. So it is shared decision making, but I think patients really look to us to make a recommendation at the end of the day and not just give them a menu. But there's often a medication or a comorbidity that will strongly push me in one direction or another.
Yeah, thank you, Dr. Caseman, for that question. So Dr. Fabrizio is asking, if you're giving monotherapy enzalutamide in a high-risk BCR patient, start with you, Tanya. If you're doing that, what are you recommending for prophylaxis regarding the breast-related symptoms?
So I will mention that there will likely be breast symptoms, and I will suggest radiation. Some patients are not interested or maybe not as concerned. I mentioned tamoxifen as an option as well, but that's a place where patient, because it's not as much of a medical issue, it's a symptom issue. Patients can choose which approach they prefer.
Gordon?
Yeah, I think it's a prospective conversation. One, letting them know that there's that increased risk compared to a combination strategy with ADT. And then two, a prophylactic radiation would be mostly the conversations that we have. Anesterol, tamoxifen, those kinds of discussions can also.
Yeah, we're heading into really great uncharted territory in EMBARK and in the ENACT study, which was monotherapy in AS. We didn't have any preventative prophylactic strategies for those breast-related symptoms. We kind of knew they were going to happen. And so we have a paper coming out. We're on the second draft. I did a review at APCCC, mostly garnered from the 150 milligram bicalutamide experience from our Nordic colleagues and Northern Europeans, which you see a similar monotherapy unopposed ARPI breast-related symptoms. We have a paper coming out on this. I think it's going to be really helpful in deciding upon the use of prophylactic radiation therapy or a SERM, tamoxifen. Actually, my data, my review says it worked much better than aromatase inhibitors. So we hope to get that published in first quarter 2025. All right, what about this question? Which treatment regimen would you recommend for patients with high-risk BCR? You see the choices: monotherapy ADT, combination ADT enzyme mono, SBRT, metastasis-directed therapy. I'm not sure. All right, here's our pre. Wow, a lot of good. And I'm going to ask you in a minute, Tanya. Oh, we're skipping that one. We're going to the next one. Okay, for purposes of time, we'll get back to that. So I mentioned early in the intro, Zero is great because nonprofit organization, the website you see here, they bring in all these great other educational materials. I use this regularly, but I also refer patients to PCEC, to ACS, PCF for sure. I never send patients to a website that has my name on it. I'm like, go and get this. I think this is a really important issue now. We are all challenged with where's trust in science now. It's become somewhat of a political hot topic, right, given the challenges we had with the pandemic. And I know everybody in this room, we're all physician scientists, but I do think that trusted organizations as trusted folks in academia and in well-established centers of excellence, we need to really be champions for this. So let me move forward with my presentation. So MHSPC, where are we? What's happened? We recognize, and I kind of really like the graph at the bottom. If you look at the survival likelihood, if you present with de novo high volume at the very bottom red versus recurrent or metachronous low volume, there's a pretty big gap. There's always exceptions, and part of it may be based upon next generation sequencing, and Dr. Baraskis-Dorf is going to talk about that. Super important. Are you testing? And if not, why not? That said, the de novo and the metachronous or the synchronous metachronous are sort of in between there. So staging matters, volume matters. Of course, volume, is it based on conventional imaging or on the newer PSMA PET? And that continues to be a source of controversy. I think it's real that we get better information. The question is how good are your interpreters, and what do you do with that information when PET converts a low volume conventional to high volume or intermediate risk or intermediate stage, depending upon how you want to talk about it. So we have a lot of unmet needs. These patients don't do well as a general rule. More and more patients are presenting this way because of the USPSTF lack of endorsement of getting PSA screening. I think we all recognize that screening is reasonable as long as you know what to do with that information. way too many patients are receiving ADT monotherapy. Bigger overarching question based upon the BCR population, the MHSBC, is there even a role left for monotherapy ADT? And combination versus mono ARPI. Is there a role for monotherapy ADT? It's kind of pretty remarkable where we've gone, all due respect to Huggins and Hodges. And so we see some discordances in the Center of Excellence, which is really the bona fides of academic tertiary centers. The community is really starting to catch up, and I think SUO, Clinical Trials Consortium, and others have really done a great job. But the question then becomes is why? Why do we have some of these unmet needs? Why are we still seeing a lack of adherence to the guidelines? So this is kind of like, should kind of really be somewhat mind-boggling, or maybe some might even call it appalling, that there's still the use of ADT monotherapy compared to second-generation androgen receptor inhibitors. I don't think there's a role anymore for bicalutamide or nilutamide or flutamide unless it's an access issue. That's your first-generation ARIs. I like the ARPI acronym better. And even ADT docetaxel as a doublet, is really no longer recommended except in the setting of triplet therapy or if you have access issues. So you've all seen this, and this is remarkable. This is the intensification, which I think is synonymous with optimization. This is really remarkable data. The Stampede H is important to put up there because that really speaks to radiation of the primary. In those patients who had low volume disease, there was clearly a survival advantage versus they not getting radiation to the primary prostate, that is. The question then becomes that sort of soft call between low volume and high volume. But look at all of this remarkable data. The most recent to it now is the ARANOTE, and I'll be talking about it. Here are the KMs in MHSPC. The proverbial embarrassment of riches. Titan with apalutamide, Arches with enzalutamide, Latitude with abiraterone. They used high risk, low risk definition, fairly comparable to the high volume, low volume, the high risk 2 of 3, grade group 4 or more, as well as 3 or more bone lesions. And so I think that we see that clearly staging matters, but at the end of the day, the low risk, high risk, the low volume, high volume all benefited from doublet therapy over monotherapy. So that's a really important lesson. So then we get to, well, if the doublets work, what happens when we add a microtubule inhibitor in the form of a taxane? They're really the key approval in 2004, which was the first life-prolonging therapy of the roughly 12 or 14 that we have now 20 years later, and it was docetaxel. And it still has a role to play. So here's the piece one, a really great study, led by Karim Fazazi, largely conducted outside of the United States, but really demonstrating how triplet therapy versus a doublet, ADT-ABI versus ADT-ABI and DOSI, the clear separation of the curves, and the hazard ratio of 0.5, and particularly in the high volume, high risk patients. And this trial was started the ARASENS, ADT DOSI, with or without darolutamide back in the day early on to really kind of recognize, and again, the synergy or the augmentation of triplet therapy. And isn't it great to see that you have a confirmatory study of an ARPI as well as with DOSI that these patients did markedly better. And so this is now incorporated into the guidelines. The most recent data that we have now adding to this to essentially put a nail in the coffin of monotherapy ADT is the ARANOTE study presented by Fred Saad at ESMO this year, and now most recently published a couple of months ago in JCO, demonstrating the advantage of ADT Daro versus ADT placebo, conducted outside of the US for equipoise purposes, remarkably fast enrollment, 30% Asian population, almost a 15% non-white, black, largely from our Brazilian colleagues. So really good diversity on inclusion there. And if you look at this, the forest plot, OS it's immature to make a conclusion on that, but clearly on the RPFS and in the time to CRPC, PSA progression, next anti-neoplastic therapy, all benefiting the doublet. Not really surprising, but nonetheless, now we have another option for our patients. This is a pretty provocative abstract that came from an analysis of a large community database in the United States, both from the Komodo's database as well as the PPS Analytics, looking over a several-year period of a head-to-head analysis of over 3,700 patients who were ARPI naive with MHSPC. And we actually did this analysis in apalutamide versus enzalutamide, and a similar analysis in apalutamide versus abiraterone. Both manuscripts are being submitted for publication, but what you see here is a take-home point that there is a statistically significant retrospective review, with those caveats, of apalutamide besting enzalutamide. So real-world use of drug, retrospective, large data set, provocative, and I think open for further discussion. We look forward to getting that publication to you. So what are the safety considerations? We've really kind of already talked about this. Oral versus parenteral, site of service differentials. Is there pill burden? What are the different toxicities? Fortunately for our MHSPC patients, they tend to be younger, they tend to have better performance status, they tend to be more risk-seeking. They want what some would say first shot, best shot. And so they potentially may be more willing to understand the taxane toxicities. You see some of them listed here. There's others, such as alopecia. And there are others too, and they're certainly not all listed here regarding the ARPI. I think we've all become much better at recognizing the toxicities of T suppression, the individual choices of ARPI, adverse event profiling, lab monitoring, and different unique issues, and then also with taxane use. For me, at least, what's changed significantly in the arc of my career, particularly in the last decade, is making sure that I do the best I can to explain to patients in that shared decision-making model and not be paternalistic and say, well, this is what you need to be doing. And I think, sadly, we still see a lot of that with our colleagues who are using monotherapy ADT. So here's a question for you. Which treatment regimen would you recommend for the majority of patients with high-volume MHSPC, conventional imaging, 4 or more bone lesions and or visceral metastases? That's really your high volume. They can have a ton of nodal disease. That would still be low volume as long as they don't have 4 or more bone lesions and no pulmonary or liver lesions. And they're fit for chemotherapy. What are you recommending? All right, so the blue is the post, and the orange is the pre. So Tanya, you see a lot of these patients, I'm sure. They're coming in, they're walking in. Fortunately, most of our MHSPC patients are typically asymptomatic. And they may have like sky-high PSAs. They're like, what the heck? I didn't know. I got a PSA by my primary care doctor. Next thing I know, I got these imaging, and I'm like riddled with disease. I'm playing golf, I'm playing tennis, and there's exceptions. But what are your thoughts about that?
So when someone's asymptomatic, of course, it's challenging to approach something like chemotherapy with them because we know in the short term they will have symptoms from the chemotherapy. I think it's a little bit easier when someone comes in pain, having lost weight, the really bad aggressive actors. There, it's a no-brainer. I really emphasize the need for that triplet with chemotherapy. But in a case like what you're describing, I certainly offer it. I talk about, the fact that your PSA goes down with the hormone therapy, yes, but we are looking not just at how you're doing immediately, but 5 years, 10 years down the road, and that the investment in maximal intensified therapy up front pays dividends in terms of delaying the time to symptoms and maintaining quality of life over the longer period.
So, Gordon, with all of this data, and you're involved in a large group, it's a multidisciplinary group, you cover a lot of satellite offices. How are you working together to create efficiencies within clinics and the multidisciplinary, given all these options?
Yeah, it's challenging. And generally speaking, we try to centralize this process regionally, right? We try to identify folks and get them into geographically amenable locations that are overseen by a champion physician and or, whether it be a urologist or a medical oncologist in our practice, to ensure that we have these sites that are geographically amenable to the majority of our practices that are kind of spread throughout the state. It allows for better communication, patient access, and kind of prevents any disincentivization for the patient coming in and back and forth. So we find that kind of multiple little hub and spoke wheel models throughout our geography works best.
So we've all had this patient. Everybody here had, okay, sky high PSA. Symptomatic, asymptomatic, you start them on either doublet or triplet. Tanya, now the patient comes back, the PSA just, it's less than 0.2. And, their scans, they're seeing regression. It's not even just stabilization. We're seeing real regression. And they're saying, like, you know what, can I get a break? Can I get a holiday? Can I de-intensify? How do you do that discussion?
So that's a really challenging one, right? The data are all with continuous therapy. And I have some patients 7, 8, 9, 10 years on first line ADT doublet. And I do think there's deterioration in physical functionality and certainly some quality of life things like sexual function that are hard as you keep going. So it's a conversation that does happen quite a bit in my practice. The data just aren't available to us. So I think we have to tell our patients we don't know if it will compromise their long-term cancer control. But, shared informed decision making with that, sometimes a treatment holiday can be given, but I usually wait at least 2 years into it to make sure we're in a good remission.
Yep. I appreciate that, but gosh, I have had some patients who are just, they're sometimes nearly suicidal with some of the side effects. And I will basically say, to your point, here's what the data is, but if you're willing to stop, I'm okay with the stop. The de-escalation, the interruption, we're just going to follow you really closely. And my empiric experience is that these patients are so happy to do that. But anyway. Yeah.
Sometimes dose modification or supportive strategies, putting someone on an SSRI, I will try to keep them on therapy. I'll try to give them options. But yeah, you're right. We have to listen to our patients. So we're moving on to the MCRPC space. So I'll be covering radioligand therapy and PARP inhibitors. So radium-223, which has been around a while, had a new spotlight at ESMO this year with some new data, but just to refresh your memory, it was approved based on the ALSYMPCA trial as an overall survival prolonging drug. So a lot of us think of this radioligand, which is bone-targeted, alpha-emitting, as being pain relief, reducing skeletal-related events, and it does that. But it also prolongs survival, and that's really important, how to categorize it when you're thinking about your therapeutic options. And in the ALSYMPCA study, patients could have had prior docetaxel, but not all did. And you can see that there was a survival benefit regardless of prior docetaxel use. However, it's bone only, and some patients will have soft tissue and bone disease. So it made sense to try to combine androgen receptor pathway inhibitors with radium so that we can control the whole picture, and also because of synergy between hormone therapies and radiation. But surprisingly, the ERA-223 trial, which was abiraterone with radium versus abiraterone with placebo, actually was a negative study and actually showed an increase in fractures. But these were not in areas of cancer. What we had seen in ALSYMPCA was a reduction of cancer-related fractures, right? Here it was more insufficiency fractures, and it was realized that patients just weren't getting bone supportive agents. So if you remember nothing else from my section of this, what I want to remind folks is that for MCRPC with bone involvement, we really need to be using our bone supportive agents because there's real harm when patients have fractures So piece 3, combining enzalutamide with radium, was ongoing when the ERA 223 data came out. And they took a look, and you can see on the right there is significantly greater risk of fracture if you're not on a bone supportive agent, whether you're on the enza alone or on the radium. So certainly when you reach for radium, reach for bone support, but all of our MCRPC patients with bone involvement need it. So these were the new data that were very exciting. Piece 3, enzalutamide radium versus enzalutamide alone in MCRPC, and they could have had prior docetaxel or not. But again, use of bone supportive agents became mandatory once the data from ERA 223 reported out. And maybe that's part of why this ended up being a positive study and really exciting, not only for progression-free survival, but actually overall survival was prolonged using this combination. So maybe some of us haven't been using radium 223 as much, but this becomes a very nice option for the patients who are MCRPC and have a significant bone burden of disease. The newer radioligand, of course, is PSMA-based, lutetium-177, PSMA-617, which got FDA approved based on the VISION trial post-docetaxel. And now we've heard from PSMA-4 and SPLASH about the use of PSMA radioligands pre-docetaxel. And there are trials moving it even earlier. So we're going to see more and more patients talking about this treatment and asking us about it. It does deliver a beta-emitting particle to cells that have PSMA expression. So that includes prostate cancer, but also salivary glands, which ends up being one of the major toxicities. The other thing is you have to do a PSMA PET scan to select patients for this treatment. In the VISION trial, the criteria were simply one lesion that had PSMA avidity greater than background, which is the liver SUVs, and no soft tissue lesions that were PSMA negative. So your bone mets, some can be avid, some can be not, but if you have visible lymph nodes or liver metastases or lung metastases, they need to uptake the PSMA, otherwise you didn't qualify. And only about 13% of patients will be excluded on this basis, but this necessitates a conversation these days with our nuke med colleagues in understanding, does this patient qualify? And probably in the future, the intensity of uptake or the amount of uptake is going to help us select patients who are going to derive the greatest benefit from this treatment. But for now, we just use the simple VISION criteria. You can see here a very nice survival benefit and very strong RPFS benefit. But what I've found most gratifying in my own practice with this agent is really that pain relief. So this Kaplan-Meier curve is lack of pain progression. But what I see actually is after a single dose, sometimes my patient's pain is significantly reduced, even within a week or two of their first dose. So that's been very gratifying. You can see quality of life measured by FACT-P. It takes longer to deteriorate. This is a well-tolerated drug, and it's really controlling the cancer quite nicely for a lot of patients, although certainly not all respond, and the median time to progression is close to the time they're finishing up their 6 doses that are dosed every 6 weeks. There's also a reduction in skeletal-related events, so clearly an active drug. So right now we're restricted by label to post-docetaxel, and obviously not every MCRPC patient is ready and willing to go through docetaxel. So thankfully PSMA-4 has reported out. This was a study in patients with MCRPC who had progressed on an AR pathway inhibitor but had not had docetaxel. And they were randomized to that same dosing every 6 weeks for 6 cycles of lutetium PSMA-617, or a relatively weak control arm, the same one that was used on VISION, which is the AR pathway switch, which we know doesn't bias a lot of cancer control. So really wish that the control arm had been chemotherapy, which is really the other option in this setting. That being said, the trial was positive for its primary endpoint of RPFS. You can see about a doubling of the RPFS. Only about 5.5 months when you do that AR pathway switch. We know Abi after Enza, Enza after Abi, not so effective, but not a placebo either. Clearly there's some disease control for some patients, but much superiority for the lutetium PSMA radioligand therapy. So we're waiting on the overall survival to be finalized and to see whether FDA moves this drug to pre-chemo. But in the meantime, again, you just really see pain control, quality of life. The side effects, it's not to say there aren't any. The dry mouth for some patients can lead to even anorexia or weight loss, but most of the time that you can use some tricks like the mouthwashes, the other biotin type products that they can get over the counter in the drugstore. There are some nausea and vomiting that I've seen in my clinic, so I've taken to prescribing an antiemetic when I start patients on this. And then, of course, we're watching those blood counts. So we really check the CBCs closely, as well as renal function. We monitor their creatinines. And in this urologic population, we have some interesting scenarios with nephrostomy tubes or incontinence with diapers, and we know that radioactivity is coming out in the urine. So those are some of the things that we've had to work through to try to administer this safely. Patients do have to isolate a little bit from loved ones for a couple days, 2-3 days after, and that does present a barrier for certain patients, but overall, well tolerated. So PSMA 617 is not the only radioligand therapy. Others are being developed, and actually this one, the PNT drug, reported out in the phase 3 SPLASH trial. So this was also in a patient population, MCRPC, but pre-docetaxel. This is dosed every 8 weeks for 4 doses. So it's a different way of attaching to PSMA and delivering the beta particle. So this was positive for the primary endpoint of rPFS compared to AR pathway switch. Again, not the strongest control arm, and we're waiting to see whether this will become approved. PSMA addition is in the metastatic hormone sensitive setting, so moving this all the way up, trying to achieve those really deep remissions and give our patients another option for triplet besides docetaxel chemotherapy potentially, which would be nice. So this was completed accrual. It's standard of care, so any kind of doublet alone or with lutetium PSMA every 6 weeks for 6 doses with a primary endpoint of rPFS. So we'll be excited to see what these data show, and then a very provocative trial looking at the use of PSMA 617 without ADT in the context of oligomets and using SBRT. So, I thought sometime before I retire, I would like to be able to have an option that was not just ADT based for my patients, and maybe, depending what we see here, at some point we'll get there. There are other particles that can be used, such as the alpha emitter actinium-225, and this year at ASCO, Michael Morris presented the actinium-225 HK2 radioligand, which is clearly active in MCRPC, and there will be others coming along, so this is an exciting space, and really only the beginning. The VISION trial gave us a great tool for our patients, but now we work on doing even better. So let's switch and talk about PARP inhibitors. We can only really use PARP inhibitors right now in patients with a homologous recombination repair alteration, whether it's germline or somatic, but we won't know who those are unless we do the testing. And it's really disheartening, the low rates of testing among our prostate cancer patients. So NCCN guidelines certainly recommends germline testing up front at diagnosis of localized disease for almost all patients, and hopefully soon all would have access. But we can't forget somatic, because the cancer can have these DNA repair alterations that were not present in germline. And if we don't do either ctDNA testing or tissue testing, then we'll miss a significant number of patients who could benefit from these very, very effective drugs. So olaparib's FDA approved as monotherapy for MCRPC based on the PROfound study in patients with one of a specific set of DNA alterations. Rucaparib also based on Triton-2 approved for BRCA mutation, MCRPC. Now, this study was really important because it actually allowed docetaxel on the control arm. So we actually saw that for patients who have a BRCA2 alteration, the PARP inhibitor was even more effective than chemotherapy, which I thought was a very important statement. So in terms of sequencing, we need to do our testing because we want to have this option for our patients, and we want to use it early because it is so very effective in that particular biomarker population. But now we have the new studies combining PARP inhibitors with AR pathway inhibitors that we'll take a look at. Why would we want to combine these drugs? It's not just A plus B equals C. It's really, there's crosstalk, right? When we suppress PARP, the androgen receptor transcriptional program is reduced. And when we suppress androgen receptor signaling, we induce almost a state of DNA repair deficiency without an actual mutation or alteration. And so they should be synergistic, and that's really what we've seen across these trials. Magnitude was designed a little bit differently than the other two. This was abiraterone and niraparib in MCRPC first line, but they knew ahead of time who had a DNA alteration and who didn't. And the arm without a DNA alteration actually was closed for futility. So all the data that report out on magnitude are in a biomarker-selected population, but it was positive in that setting. PROPEL and TELEPRO-2 took all comers, and they knew the DNA results, but they randomized them without using that, and then just stratified the analysis afterwards. So here are the data for magnitude, niraparib plus abiraterone in the BRCA subset. Clearly a very strong hazard ratio for both rPFS and to a lesser extent overall survival. And there's some thinking about needing to lower the dose because of drug-drug interaction, maybe part of the issue. But it is FDA approved in patients with a BRCA alteration and comes as a combination pill. PROPEL studied abiraterone and olaparib in all comers and was positive, but the bulk of the benefit does seem to be in the BRCA altered subpopulation, which is a consistent theme across these trials. So we do need to do testing to select patients who benefit most from this strategy, but you can see quite striking benefit. And then TELEPRO-2 was enzalutamide with talazoparib, same sort of population, MCRPC, and we can see a substantial benefit. In this case, the FDA approval is for not just BRCA altered, but any of the HRR qualifying mutations to get into this study. And if you saw on this slide, you can see that those gene lists are actually a little bit different. So this becomes very complicated. But the bottom line is MCRPC patients who have not had progression on a prior AR pathway inhibitor, we need to do the testing, and they can benefit from a combination. Anemia is the major side effect. Some patients will end up needing even a blood transfusion. But if you really watch the hemoglobins and do some dose holds and dose modifications, sometimes you can avert that. And then there can be some GI side effects as well. It's nice that we haven't seen much in terms of AML and MDS. That was a concern. And as we try to move these drugs earlier, it's something we're going to have to continue to watch for. But here are the rates of grade 3 anemia. You can see ranging from 20 to 40%. So hopefully we've saved some time to answer questions from the audience.
Yeah, we do. So let's leave this up here for a second. We have a bunch of great questions. One from Dr. Labate. He wants to know, do we risk accelerating clonal resistance if we start a chemotherapy in this sensitive state? Is that a concern?
I actually think the opposite. I think we have populations that we know are going to resist our androgen receptor targeted therapies. And maybe if they are susceptible to chemotherapy, which I think the data suggests, we get out those populations and maybe avert that more aggressive clonal expansion. Although I can't say we've proven that, right? Yeah. But I think that's the thinking behind triplet therapies, and maybe lutetium PSMA will be another way to do that, or PARP inhibitors up front.
I totally agree with that. So Gordon, here's a question from Dr. Monroe. How can a smaller community practice coordinate efforts to effectively implement radioligand therapy?
Yeah, I think it's a fascinating question, actually, and it's one of those things that one, you have to identify the patients, and two, I think you have to partner with either your regional nuclear medicine physician or radiation oncologist, depending on who's infusing. Certainly, we have these patients within our practices. Like most things in advanced prostate cancer, you have to look for these patients actively. If you don't, you can miss windows of opportunity to impose really impressive outcomes. So I think it's fairly straightforward. It has some infrastructure demands that if you're not already giving radiation radioligands within your office, there are some changes between the alpha and beta, requirements and radiation licensure modifications. So independent of that, change in your infrastructure, certainly identification and centralized referral to people in the community doing it, I think it is pretty easy to accomplish.
So let's just stay on the lutetium topic. We had an interesting question from Dr. Michigan, who asks, this monitoring the CBC concerned about cytopenia. How often do you see it? How do you resume if you see some cytopenia? What are the transfusion requirements or growth factor support issues? Maybe you want to tackle that one?
Yeah, so I think it's critical that you, as the person taking care of this patient with MCRPC, remain engaged and see the patient, look in their mouth, check their CBC, and try to help them through it just like you would any other treatment they're on. And it's a little known fact, but you can dose reduce lutetium PSMA 617. So if you're seeing cytopenias and yet you're seeing the patient is benefiting from this agent, you can work with the administering physician to provide a lower dose. And we've done that in some cases. Some of these patients with MCRPC have already come in with cytopenias, and yet we don't want to deny them this treatment. And so sometimes you extend the interval, sometimes you lower the dose. It's just like modifying any other drug, even though it feels so different because it's being administered by nuc-med or radonc.
Before we get to the PARP inhibitor combo, which I think is really interesting, which also morphs into this whole notion around do I test, don't I test? Gordon, here's a question for you. It's a comment and a question. It's from Dr. Fabrizio again. His comment is, I want to send all of my advanced prostate cancers to Dr. Dorff. Is she still seeing patients? But I'm going to ask you, what do you make of the real world comparator studies is his question. When we sometimes lack the comparator prospective, we go back retrospectively, we look at this real world data, kind of gives us something, a little snapshot, but what do you think?
It does, but some of them are designed with a fair amount of statistical rigor, actually, right? So, I mean, it doesn't obviously rise to the level of level 1 evidence, but nonetheless, the way that these are designed statistically really validates their findings in a vast majority of cases. So I think these findings are compelling. We've seen both responses and differences with PSA 90 responses, less than 0.2, nadir PSA responses, and here seeing, your work that you published, as well. So I think it's not only hypothesis generating, but I think it's probably a real signal, based on the robustness of the design.
Yeah. So great answer. So let me ask you about this whole issue, debate, controversy about PARP inhibitor combination. I think there's a sort of interesting conundrum. Some of us who are doing these studies, and probably most of everybody in this room, and maybe the folks online too, we're using doublet and triplet in the MHSPC, and all these combo studies were basically predicated upon patients not receiving prior ARPI. So you have Magnitude, which is niraparib and abiraterone. You have Propel, which is olaparib and abiraterone. You have Talipro-2, which is enzalutamide and talazoparib. So now let's assume, here's my case question for you. Somebody comes in, they find you, they've been on monotherapy ADT, and now they haven't been tested. Shame on that referral, but now you've tested them, and they're both germline and somatic BRCA2. How do you make the decision? You now have approval for all three of these combos. How do you think about that? And of course, maybe make some commentary about the importance of testing. Maybe start with you, Gordon.
Sure. So one, obviously, testing is going to be the cornerstone to being able to identify these patients appropriately. It's something that even we do, I think, not as well as we probably should, in all honesty, even though we have a very robust program. But when you look internally at our numbers, they're not probably as high as they should be, but they're much better than the national average. One, two. When I look at the comparator data, I look pretty much at toxicity. To be honest with you, I look at rates of grade 3/4 anemias in terms of choosing therapeutic options for that patient population. The real challenge we're having is that we're not seeing that patient come to our clinic, with that kind of untreated ADT alone patient with the MCRP setting. But certainly if they are, they're being, having a discussion around toxicity primarily as a driving factor for us.
Yeah, I think it comes back a little bit to the partner drug. How do you choose between abiraterone and enzalutamide, right, in the metastatic hormone-sensitive setting or biochemical recurrence or, all these settings we've talked about. So some of it comes down to that when we have these choices. But I definitely think toxicity profile matters even when we're looking at these doublet combinations.
Yeah. Yeah, we didn't get to it, but the Brackaway data, that small but really significant phase 2 study, is you can't make up for it if you miss the combination early on. You got to start the combination early on. Okay, again, really zero, great site, trusted, authentic, and we kind of all really need that for our patients and their families. And the winners are, I'm waiting to, okay, I've got it here. The winners are Doctors Fabrizio and Michigan. Please see a peer review team member on your way out to receive your free card. Whoa, card, not car. Card. Okay, thanks everybody. Great questions. Have a great rest of the meeting.
Thank you.